Hi, I'm Sylvie from HR.com, and I'll be your webcast host today. We're happy you could join today's webcast entitled Copay Accumulators Part 2, a legal and regulatory update, data, trends, and patient spotlight, sponsored by Aimed Alliance and presented by their guests. This webcast has been pre-approved for one HRCI and one SHRM credit. Please be sure to attend the complete webcast in order to receive your credits. Throughout the webcast, you are welcome to submit your questions using the Q&A tab on your controls. And it's now my pleasure to turn it over to our presenters and Aimed Alliance.
Sylvie. Good afternoon, everyone. I'm Stacy Worthy. I'm counsel to Aimed Alliance, and today I'm joined by Rick Fry of Trial Card, Jennifer Hepworth, a patient advocate, and Terry Wilcox of Patients Rising Now. A little bit about our two organizations. Aimed Alliance is a nonprofit health policy organization that seeks to protect and enhance the rights of healthcare consumers and providers. And Patients Rising Now is a national nonprofit organization dedicated to advocating for the rights of patients with chronic and life-threatening illnesses. So just a quick preview of what we're going to be discussing today. I'm going to provide an overview of Copay Accumulator programs and the current legal and regulatory landscape. Then Terry and Jen will discuss Jen's experience with Copay Accumulator programs. Rick will go over recent data and trends, and we'll end with a short Q&A. So just to start, to level set, Sylvie, if you could launch the first poll. We want to know, do you know what a Copay Accumulator program is? So you can select yes or no. Okay, so it looks like a little bit more, 66% say yes, 34% say no. So we will go over the basics of what they are. Close this. So just to give you a little bit of background, it should come as no surprise that deductible amounts are on the rise and high deductible health plans have increased in popularity. Some employers offer only high deductible health plans. And in addition to that, it's not a given that those high deductible health plans will have associated health savings accounts, or that those accounts will even be used if employees do have them. So there was a recent JAMA study that showed only 1 in 3 with high deductible health plans one in 3 with high deductible health plans do not have an HSA, and 55% of those with an HSA do not contribute to it. High deductible health plans also come with their challenges. The deductible phase can make necessary care unaffordable for those with chronic conditions. So they may forego or delay medical care. They may ration their medications. They may be unable to pay their medical bills. Copay assistance can help with this. So copay assistance is typically coupon cards from drug manufacturers that help cover the cost of co-payments or co-insurance, and they also help spend down the deductible or annual limit. They allow the employee to get out of that deductible phase and into the coverage phase of their health plan sooner. So what are Copay Accumulators programs? Well, they're health plan policies that prohibit copay assistance from counting toward the enrollee's deductible or annual limit. They are often difficult to locate in the plan because they use confusing language. So sometimes they're referred to as out-of-pocket protection program, which makes it sound as though they're conferring benefit. Sometimes they're not disclosed at all. Oftentimes they're not disclosed in open enrollment materials or summaries of benefits. So even when they are disclosed, enrollees usually don't learn about them until after they've already selected their health plan and they're locked in. Enrollees are often surprised when a couple of months into the plan, they find out that they owe a hefty copay that had previously been covered, and this is not something that they typically plan for. This lack of transparency can result in violations of ERISA or other consumer protection laws that impose duty not to mislead or not to engage in unfair and deceptive practices. Additionally, some plans use discriminatory language by singling out enrollees with specific health conditions, which could also violate the Affordable Care Act's non-discrimination provision. So this is a health plan, a sample language from a real plan. This is a large employer. It's their 2020 health plan. And this is actually an example of a copay maximizer, which Rick will explain later in detail. But I wanted to point this language out for two reasons. First, it's described as a specialty medication copay card benefit. So again, it's using that confusing language that makes it sound like something positive for the enrollee. And then second, it singles out those specific health conditions. These are the only ones that the program applies to. And you can see there's conditions on there such as cystic fibrosis, cancer, HIV. So on paper, you can see just how discriminatory it looks just on its face. So why are copay accumulator programs used? Well, health plans use them to collect the value of financial assistance and extend the time the enrollee is in the deductible phase of the plan. So plans are essentially banking on a patient abandoning a high-cost medication because the patient cannot get out of that deductible phase. And while cost savings to the plan may sound enticing, there's no guarantee that any cost savings will actually be passed to the employer, given that those savings typically go through middlemen first, such as pharmacy benefit managers. Plans argue that copay accumulator programs steer patients to lower cost generic medications, but plans already use utilization management techniques for that, such as step therapy or prior authorization. And there are also there's statistics from a recent study, which you can see here, that shows that 4 out of 5 new patient claims are subject to benefit utilization management restrictions. So only after they get through those hurdles are they able to access those medications that have copay assistance. Additionally, many of the medications for which copay assistance is available do not have generic alternatives. There's a very low percentage, 0.4, of copay assistance that is used on brand drugs for which generics are available. So how do copay accumulator programs impact employees? Well, patients only receive a finite amount of copay assistance. Employees with chronic or complex conditions may not be able to access their medication once that assistance runs out. At that point, they may stop adhering to their treatment plan, they may switch their medications, or they may stop taking medication altogether. And these actions can result in disease progression, relapse, increased visits to the doctor or hospital, increased healthcare utilization. So essentially driving up the cost on that medical side of the health plan. And this is especially problematic during the COVID-19 pandemic, when patients with complex underlying health conditions are at higher risk for severe illness. So the CDC has recommended that they be able to maintain their underlying health conditions, stay on the medications that work for them. And then additionally, you have the economic downturn where employees, spouses, or partners may have lost their job. Perhaps there's less income in the household. So that copay assistance is really important, and it's really helpful to spend down that deductible. So we're gonna go to poll question number 2. So Sylvie, if you could show that question. And here it is. And it is, so now that you kind of understand what a copay accumulator program is, do you offer, if you're the employer, or are you enrolled in, if you're an employee or general consumer, a plan that has implemented a copay accumulator program? And the answers here are yes, no, or unsure. Okay, helpful to know. Okay, so moving on. So employers should know that some states listed here have enacted laws to limit the use of copay accumulator programs. There is some variation from state to state. Some prohibit copay accumulators altogether, and some only prohibit in instances in which generic medications are not available. And these laws do not apply to risk or governed health plans, but it's still important to be aware of them, especially if any of your employees are considering getting an exchange plan. There's also been some federal regulatory activity, which I'll go over now. So first is the Notice of Benefit and Payment Parameter, NBPP. This is an annual regulation from the Centers for Medicare and Medicaid Services, or CMS, that governs health plans, including employer-sponsored plans. So last year, NBPP 2020 came out that governs plans for the 2020 plan year. And it stated that plans could only implement copay accumulators if generic medications were available. So it struck a nice balance because it steered plan enrollees to lower cost medications when they were available, but also recognized that copay accumulators are not appropriate if plan enrollees do not have access to generic alternatives. So this was considered a major win for patients and a nice compromise for industry. So this year, CMS released NBPP 2021, which revoked these protections, unfortunately. So in this year's rule, which came out in May, it says that plans can implement copay accumulator programs however they want without regard to whether generics are available. However, it is important to note that it clearly states that plans are not required to implement copay accumulator programs. And it still encourages plans not to implement copay accumulators when generics are not available. It also encourages increased transparency regarding disclosure of such plans, and it reminds plans not to implement accumulators in a discriminatory manner. This is just some of the language that can be found in NBP 2021, sorry. And you can see CMS essentially says that they believe plans will choose not to implement copay accumulator programs. They say they believe plans will continue to allow assistance to account toward deductibles and annual limits. It also says that CMS anticipates accumulators will have little anticipated impact on patient adherence. As you will see, CMS pretty much changes its tune on that position just a month later. So this is just 1 month later, and after the NBPP 2021 was released, CMS also released a new proposed Medicaid rule. In it, CMS clearly changes its position on copay accumulators. So the agency acknowledges that the purpose of drug makers' copay assistance programs is to provide financial aid directly to patients, and that patients do in fact benefit from these programs. The agency also explicitly acknowledges that health plans take advantage of these programs by implementing copay accumulators. So contrary to the purpose of copay assistance, the health insurer, rather than the patient, benefits from the accumulator program. CMS also acknowledged that accumulator programs extend the time that the patient is in the deductible phase of the plan to the detriment of the patient, and that the patient is often unaware of the accumulator program, resulting in surprise when they receive that significantly higher bill. So think this is akin to those surprise billing. However, CMS's solution was that if a private health plan imposes a copay accumulator program, then any copay assistance collected by the health program must be counted toward the Medicaid best price calculation. So as background, under Medicaid best price rule, drug makers must give Medicaid programs the lowest price for prescription drugs, subject to certain exclusions. And traditionally, copay assistance had been excluded because it was assumed that the benefit was conferred onto the patient. However, under this proposed rule, the drug maker must ensure that the assistance goes to the patient and not to the insurer. The problem is that patients and drug makers have no control over whether plans use accumulators. And they're often unaware of which plans have accumulators due to lack of transparency, which I discussed a little bit earlier. And there's no real way to ensure compliance with this rule. On top of that, in light of the MBPP 2021, health plans are now more likely to implement copay accumulator programs because they've been given express permission to do so. So the likely outcome here is that drug makers may restrict or stop offering copay assistance altogether because they don't really have a way of complying with this rule. So the final rule is expected out soon. However, if you want your employees to have access to copay assistance, you may want to contact CMS and ask them not to finalize this rule. The official comment period did close, but you can still send letters and reach out to them nevertheless. It just won't be in the official docket. Alternatively, don't select a plan without copay accumulator program because if you do, employees may not qualify for assistance. And then just to sum things up and make some recommendations, you are not required to implement a copay accumulator program. You want to consider avoiding copay accumulator programs, especially in combination with high deductible health plans, or at least offer one plan option without an accumulator. If you do select a plan with an accumulator program, make sure it's limited to instances in which both branded and generic medications are available so that the patient has an alternative treatment that they can select if they need to. And then you want to clearly communicate the existence of the policy during open enrollment period in very plain language before the enrollee is locked into that plan. And then do not apply the policy to specific diseases or conditions because that could be considered discriminatory. And then finally, allow patients to request an exception and if from the copay accumulator program, and if their exception is denied, deem that denial an adverse benefit determination, which they could then appeal. So with that, I'm going to now turn it over to Terry and Jen.
Hello, this is Terry Wilcox with Patients Rising Now. I'm going to be talking to a patient advocate in Utah who has had some experience with copay accumulators. But prior to starting, I just want to give a couple of examples of actual patients that we've worked with who have come upon copay accumulators and what that has caused. The first one is a patient, excuse me, who is in a she's self-employed. So she's in a, she's in her own plan. I guess you call them marketplace plans. And in any event, she didn't know a copay accumulator was being implemented because it had been covered the year before in her plan. And this woman has MS. She's healthy, except for the fact that she has MS. So she doesn't really have a lot of other medical expenses, but MS drugs they're quite competitive and they're quite expensive. And therefore, copay assistance plans have been implemented. That's one of the reasons why in Stacy's slide, you saw a bunch of those different specific disease states, because those are disease states that oftentimes have a lot of back and forth between manufacturers and PBMs and insurers because there are so many different options and the rebates are often quite extensive in those disease states. She ended up having, when she went to renew her plan, the cheapest plan she could find was $750 a month for her premium. And then she had copay assistance to help offset her medicine. Well, they also implemented a copay accumulator, at which point she couldn't really afford anything. She couldn't afford the $750 a month. She couldn't afford to get through the $8,900 deductible, which is a combination of her, I guess, deductible and then her maximum out of pocket. And so she ended up having to go through a whole bunch of processes, ended up getting her drug covered from the manufacturer, but still is constantly roughly 15 to 20 days behind in getting her medicine when she needs it, because she still has to go through all the stuff with the middlemen and dealing with overriding the copay accumulator. So even when she's getting it for nothing, she's still having a lot of processes to go through. And in addition, she's now making cash deals with her doctors and not even using the insurance because it's cheaper. So that's just a prime example of how this has taken a patient who her only real expense is the medicine. She's forced onto a high deductible health plan because of her situation. They don't have a lot of options as obviously independent contractors or small businesses. And so therefore she's kind of stuck in this place. Now my second example is, is an employed person actually in a state that has a copay accumulator ban. That's Virginia. Now his employer implemented a copay accumulator for his medicine, which he's got comorbidities. So he has a psoriatic arthritis and insulin, both. Virginia also has a maximum out of pocket on insulin, which is $50. It has nothing to do with copay accumulator, but because he is in an employer plan that is self-funded, obviously doesn't apply to him. So the copay accumulator ban nor the insulin maximum out of pocket helps this guy. And now he's in a situation where he's actually possibly going to have to quit his job because they've implemented a copay accumulator, creating an expense, an additional expense for this man of almost $4,000 a year without raising his salary. So they've taken away his lifeline and not raised his salary. And so that's an example of an employer sponsor, which is probably of more interest to you, of how even when you have policy things in place that folks like Patients Rising Now and AIMED Alliance have fought for, they still don't always work for everybody, and people fall through the cracks, which is why it's so important that employers understand how these work and how they affect the people that they employ. And with that, I'm going to introduce you to Jen Hepworth, who is from the great state of Utah. And so say hi, Jen.
Hi, everyone.
Jen, I want to start off by why don't you tell us you ended up becoming an advocate around this in your state, but what led you to get there? What prompted your copay accumulator advocacy?
I have a 7-year-old daughter who has cystic fibrosis, and one of her medications is $300,000 a year. And it's a phenomenal medication. She is thriving on this medication, and we had it covered, and copay assistance was able to help us because we would meet our deductible January 2nd when I would fill her medication, and then be able to move into our out-of-pocket portion of our insurance. And then without our knowledge, our insurance company implemented copay assistance program, copay accumulator program. And all of a sudden, my husband and I are on the hook for our $6,500 deductible on January 2nd so we could get her this medication that she absolutely needs. So, and to tell you how important this medication is, she went from when she was born to having a hopeful life expectancy of 37 years. And you can imagine how it feels holding your 3-week-old baby and being told about her life expectancy, to having this medication, and she could be a great grandma. And so we scrambled and we put everything on my credit card, and because we can't not give this medication, and went about our year because that is what you do. And then the next year when it happened again, I talked with my daughter's pharmacist, and he told me that it was happening in more and more plans. And I was like, well, we got to figure out how to do something, because while maybe I can absorb $6,000 of debt, a lot of families cannot and are completely maxed out. And we are a very, very close-knit cystic fibrosis community here in Utah, and I wanted to be able to help not only my own family, but other families as well. And so we started, I independently started jumping into advocacy, which is something I had never done before, and started banging on my legislators' doors, so to speak, and started trying to figure out a way to get these banned in my state.
And actually, from your particular plan, Jen, yours was your husband's, correct? Was it his plan?
Yes, my husband works with a very large employee, yeah.
Right, large employer. It was a large employer plan. I mean, and a lot of, and you just really gave this information by saying, you know, on January 2nd, I had to go into debt for my entire deductible on that day. And one of the pushbacks on copay accumulators often and I've actually heard it out of the mouths of employers and insurers and others. They say, well, it's not fair that some patients get support for their deductible and other patients don't. And that is true. I can completely understand that statement. However, to the point of you having to do this all on January 2nd, generally when we get sideswiped with a large hospital bill or some other kind of bill like that, they take care of us and then they send us a bill, right? Mm-hmm. And then we have to figure out how to pay that bill. That's not the case here.
And I feel like when you are in a chronic disease state, like so many of people in this country are, you have to plan on meeting your out-of-pocket maximum every single year. And healthy families or people without pre-existing conditions are not going to plan to meet their out-of-pocket maximum every single year. It's taking your kid to the pediatrician, and maybe you need eyeglasses, and maybe you have anxiety medication, but you're not planning on $300,000 of medications every single year like chronic conditions do plan.
Right. It's true. It's true. And, you know, every once in a while, it's like I met my maximum out-of-pocket deductible when I had the year I had my twins, right?
Right.
Had a pregnancy. So therefore I met that, but we don't meet it every year now. So I get your point, and many do not, which is why health deductible health plans often work for the healthy more so than they do for folks in positions with chronic illnesses and the like. So as far as going forward with Copay Accumulator, with your Copay Accumulator advocacy, do you have any plans to resurrect any advocacy around this in Utah going forward into 2021?
Yes, so we called the 2020 session in Utah my learning session. I learned a lot about things. I also learned that one mom and two pharmacists alone can't change everything when you're going up against insurance companies. And so we are reaching out, getting some more allies to help us, and we will be hopefully finding a sponsor for a Copay Accumulator ban in the Utah legislation and going forward with trying to get it banned.
No, well, that's great. I mean, that's kind of how we met around your advocacy for that, because we were doing our advocacy on the Hill around the NBPP rule, which Stacy just spoke about. So, well, thank you very much, Jen. Go ahead. Sorry.
And I would just like to say that this is not something that I am a professional at. Like, I am a stay-at-home mom. I have 4 kids. This is not something I ever saw myself doing, but because of these Copay Accumulator programs, I've been thrust into this world that I really don't understand. And this is a lot of what the employee families are having to deal with. And so this is not just one woman's plight. This is all over the country. Every business is going to have somebody that is affected by this. And so this is very, very personal. It's not just a peripheral thing in our family. It is, we think about this all day long.
No, I know. And it's unfortunate that the shift in the supply chain issues around rebates and all the rising costs in the mucky middle, as I always like to call it, has caused a lot of this cost shifting back onto patients, which is absolutely where it should not be. I mean, I think they're bearing enough of the burden with just being sick, and hopefully we can start to see some changes in that area. At least that's what we're fighting for. So, Stacy.
Yes, thank you. Thank you both. It was really great perspective to hear. So with that, we're going to turn it over now to Rick. So Rick, go ahead and take it away.
Sure, thank you. And thank you, Stacy, for inviting me to be part of this webcast today. And thank you to everyone who has participated. This topic in particular is something that myself and the company I work for, TrialCard, has been immersed in, and really has been laser focused on doing whatever we can to support patients through these issues, and ultimately try to change the the direction the industry's headed in. Just for perspective, TrialCard is a company that works in the pharmaceutical service industry. So we work on behalf of pharmaceutical manufacturers, providing a variety of services to patients and providers. But really, in a nutshell, you can think of our company as at the core of what we do. It's all about helping patients gain access to the medicine they're prescribed, overcoming any sort of insurance barriers, affording that medication, and then staying on that medication, for the long haul. And we do that in a variety of ways. But just to kind of ground you in where my head's at, where my perspective is, that's kind of where we sit in the industry. Unfortunately, we hear this every day. We're in a very unique position in that we talk to patients, pharmacies, insurance plans, healthcare providers every day, and we see this happen every day. So just like Jennifer mentioned, this isn't an issue impacting a small number of people. This is a significant issue impacting thousands, if not millions, of Americans with chronic conditions. So go ahead and go to the next slide. Just a quick overview of what we'll talk about. And just also to mention, I've got a lot of data, like Stacy mentioned. We'll have the slides available afterwards, so we may go through these fairly quickly. Go to the next slide, Stacy. So Stacy did a really good job explaining, what these are and how they work. At the core of a Copay Accumulator program, what's happening is that the health plan, through the PBM and the specialty pharmacy, does not count the value of the copay assistance towards a patient's cost-sharing obligation. And when I say cost-sharing, I mean deductible, co-insurance, copay, anything that's assessed to the patient. The byproduct of this is oftentimes when patients exhaust the available amount of copay benefit, they hit what we call the copay surprise. An offshoot of these programs are what's commonly referred to as maximizer programs. And the way these are a slightly different or a variant of a Copay Accumulator program is they'll typically take the available program benefit and distribute it evenly over the course of the year or close to it. So the benefit being, when benefit, use that loosely, to the patient, is that the patient has the benefit of that copay assistance throughout the year, but the full value of the copay assistance offer will be utilized over the course of that year. And at the end of the day, the goal here in what pharmacy benefit managers and health plans are doing is trying to shift costs back onto the drug manufacturer and the patient. Go to the next slide. And I'm going to run through a couple examples. Stacey, you can go to the next one. And then you can build this out. I didn't realize we had it building out. But so operationally, from the perspective of the patient, how this looks is they get prescribed a medicine. And in the case of a specialty medicine, this is typically going to be something handled over the phone. But the copay assistance program, their prescription is going to be sent to the pharmacy. The pharmacy is going to bill their health plan, or the pharmacy benefit manager. They're going to determine if drug is covered and determine how much out-of-pocket responsibility the patient owes. The pharmacy is then going to bill the copay assistance program administrator, a company like TrialCard. They're a number in the industry. They'll then adjudicate that claim as a secondary payer and then determine how much, if any, the patient owes. The patient will then pay any remaining out-of-pocket, typically a fairly low amount, and the medicine will be dispensed. The key here is that the patient receives credit towards their deductible and their out-of-pocket maximum, or the amount paid by the copay assistance program. Now we'll go to the next slide, and we'll imagine a hypothetical scenario. This is a hypothetical, but it is very real in the sense of these types of programs are very common in some of the disease states that Stacy showed earlier. Oncology, multiple sclerosis, things like that. These very generous programs are very common in the industry. And then we'll look at a hypothetical health plan. This health plan has an individual annual deductible of $2,500. Following that, a 20% coinsurance and a $6,500 individual out-of-pocket maximum. this drug has a monthly cost of $10,000. So we'll step through what this process looks like and what the patient will experience. So let's assume the patient starts therapy in January. In this case, we're looking at a health plan that does not employ a copay accumulator. In January, the patient's cost share responsibility, what the pharmacy is going to ask them to pay, is $4,500. That's made up of the $2,500 deductible, followed by 20% coinsurance. That will get passed down to the manufacturer's copay assistance program, who will pay that $4,500, and the patient will pay $0. With no copay accumulator program in place, the patient gets credit of that amount towards their out-of-pocket accumulator within the health plan. So this is what is getting added up to determine when they hit their out-of-pocket maximum. So when they come back in February, they've already been given credit for $4,500. In this case, the health plan can only assign them an additional $2,000, that coinsurance. The manufacturer copay assistance program will pay that $2,000. And at this point, the patient has satisfied both their deductible and their out-of-pocket maximum. So when they come back in March and for the remainder of the year, they have no cost share responsibility and they don't pay anything for that drug with each prescription. So next we're going to look at what happens when there is a copay accumulator program operating with the health plan. Okay, so you can build this one out again. I won't step through all of it again because it is very similar, but I'll call out a couple key distinctions. In this case, where we see these typically in place is where the patient is using the health plan pharmacy benefit manager's wholly owned or preferred specialty pharmacy. So in the industry, a small number of PBMs control the vast majority of beneficiaries, covered lives, and they're vertically integrated, so they own their own specialty pharmacies, which makes this type of arrangement fairly easy to administer. So the patient will be going to the health plan's wholly owned specialty pharmacy. And the way this differs is after the copay assistance program is applied, that specialty pharmacy then reports back to the health plan's pharmacy benefit manager to essentially take away that credit that they received for the copay assistance. So with each and every prescription, they're not getting that credit towards their deductible and out-of-pocket maximum. So we can go to the next slide. So if we step through that same scenario that we looked at before, patient starting in January, their cost share responsibility is $4,500. The manufacturer program pays $4,500. But here the difference is the patient is not given that credit towards their deductible and out-of-pocket maximum. So as they go through April, the patient is likely unaware that there's anything happening in the background because they're paying $0 for the first 4 months. But when they get to May, they've used $18,000 of the available $20,000 benefit. So now when they go to use the copay assistance offer, there's only $2,000 remaining. So the patient has been asked to pay $2,500, which we call the copay surprise. And at that point, they're at high risk of abandoning therapy because it's probably an expense that they weren't planning on, didn't account for, and now have to figure out how to pay. If we assume that they can pay it, they will get credit towards their deductible and out-of-pocket maximum at that point, and the process will then repeat in June. The difference here in June is that $2,500 has satisfied their deductible, and now they're assessed the 20% coinsurance. But over the course of May, June, and July, this is where we see patients, and unfortunately we see it very, very often. This is when patients stop their therapy because they're not able to pay. With chronic conditions, this could be a life-threatening issue. It could be a life-altering issue, but it definitely puts the patient in the middle in a very bad situation. We can go to the next slide. The last thing that I just wanted to show a comparison. These are the same hypothetical scenario that we just stepped through. The slides I showed before covered the first area, what we consider a normal health plan or health plan without a copay accumulator employed. The bottom section is with the copay accumulator employed, same numbers where we look at patient cost share, what the copay program pays, and the patient's final out-of-pocket responsibility. In the middle is what we call a maximizer program. The difference here is that the health plan and the PBM essentially have knowledge of the copay assistance program for most of the branded specialty therapies on the market, and they will actually adjust the patient's, you can think of it as a copay, they'll adjust the patient's copay for these drugs equal to about 1/12 of the available annual benefit, or whatever increment makes sense for how that drug is prescribed. So in this case, the patient's copay responsibility is 1/12 of the available program benefit that the program will pay. The benefit to the patient being that they don't hit that copay surprise. However, they're still not given credit towards their deductible or out-of-pocket maximum. TrialCard has been tracking this very closely since we started seeing these types of programs begin to proliferate really in early 2017. What we're looking at here is a sampling of 5 different disease states that are very, very widely represented with a number of branded products and a number of copay assistance programs. And what we're comparing is essentially year-to-date 2020 to about the same point in 2019. The way we identify impacted patients is when we see evidence in our pharmacy claim data that patients are not getting credit towards their deductible and out-of-pocket maximum when they use copay assistance. So this shows the growth just from last year to this year in patients impacted. We say that this is essentially the very lowest number of impacted patients, because what this doesn't account for is patients that have other healthcare expenses. So a pregnancy was mentioned earlier. There could be cases where a patient is in a health plan with a copay accumulator program, but they have some other major medical expense that does in fact satisfy their deductible and their out-of-pocket maximum early in the year. And they're also on some sort of expensive specialty therapy, prescription drug. We wouldn't be able to pick that up in our data. So this is actually essentially the very lowest number of impacted patients. In reality, there's a much higher number of beneficiaries and plans with copay accumulator programs. So we see it, and when I say TrialCard sees the impacts of these types of situations in our data every day. We hear anecdotally on the phone from patients and caregivers and prescribers every day, when they're hitting the copay surprise, when they run out of copay assistance program benefits. But there have been 2 studies done recently, and there have been more, but these 2 studies kind of hit to the core of the issue. They're actually both released about this time last year. The first one I'll highlight was in the American Journal of Managed Care. These are peer-reviewed journals, and this actually looked directly at the impact of copay accumulators on specialty drug adherence. I highlight some of the key findings. What this looked at was 10 months after the copay accumulator program was impacted, the affected patients had 233 fewer drug fills per 1,000 patients, 20 percentage points higher treatment discontinuation, and 12 percentage points lower proportion of days covered. Proportion of days covered may be an unfamiliar term, but essentially what that means is if you were to look at, say, a 90-day period, a 3-month period, and you were able to look at the amount of drug the patient had been dispensed over that period, you would say, if they had 60 pills dispensed during that 90 days, they were covered 2/3 of the time. So that's how to interpret that number. What that sort of leads to is this hypothesis that when patients are less adherent to specialty medicines, they're going to have negative health outcomes that can impact the other side of the health plan spend on the medical benefit. And that kind of dovetailed nicely into this other study in the Journal of Managed Care and Specialty Pharmacy that looked at one copay assistance program in particular for a drug that probably everyone's familiar with, Humira. And it looked at patients enrolled in the support program versus those not. So patients enrolled in the support program had 29% higher adherence and 22% lower discontinuation. What that resulted in ultimately was total health plan costs were lower by 9%. What you'll find in that study is the prescription costs were actually slightly higher, but the positive effects of patients staying on therapy using a copay assistance program actually lowered the total overall spending by the health plans. We go to the next slide. What we want to stress, and Stacy did a really nice job kind of highlighting this already, is that from an employer standpoint, somebody who's offering health plan benefits, is consider the full impact of what these programs may do. So from a patient perspective, I've worked in this industry for a number of years, and had I not worked in this industry, I would have no idea how these programs work. And that's something that kind of Jennifer alluded to, is this is such a hard issue to understand. You can't expect your employees, your beneficiaries to understand how this works. So there's going to be a lot of confusion, a lot of stress when these types of situations hit patients. Patients are going to be at much higher risk of stopping their therapy. That will likely result in negative health outcomes due to that non-adherence. That could lead to frustration with the health plan as well as the employer. Financial toxicity is just such a descriptive term when it comes to this issue. That's the negative impacts of the cost of healthcare to individuals. And then the last thing is, this can be a sort of an exponential impact on families with hereditary conditions such as hemophilia, where a number of people in the same family are reliant on these types of copay assistance programs. If you can go to this, maybe the last slide. So some things that TrialCard thinks about when we talk to audiences like this is be very open and transparent about how the health plan works, so that employees know what to expect. If nothing else, it would be nice to offer plans that that are on sort of both sides of the equation, that may have a Copay accumulator and those that may not, so that they know what they're signing up for. If you're in a situation where your hands are tied, the happy medium, which we by no means endorse, but would be a type of accumulator program that doesn't leave patients with that copay surprise. It's still, in our view, not necessarily the best way to go, but at least they don't hit that midpoint in the year where they're left with a very large bill that they weren't expecting. And then lastly, kind of as the studies indicate, consider the total cost of these programs, not just your pharmacy benefit, your prescription drug spend. Consider what that may do towards your medical drug spend, as well as what it may do to employees that actually suffer negative health outcomes, both in terms of loss of productivity, in terms of the work they're able to do, as well as their morale and job satisfaction. And with that, I covered a lot of information very quickly. I'll be happy to take questions both on this webcast, as well as feel free to email me afterwards. Thank you.
Great, thanks so much, Rick. So before we go into the Q&A, we just have 2 more poll questions. So Sylvie, if you could show the next poll. So in light of this presentation, have your views changed on copay accumulator programs? And the answers here are yes, I view copay accumulator programs more negatively. Yes, I view copay accumulator programs more positively. Or no, my views have stayed the same. Okay, very helpful. And we are going to move on to one more poll question. Are you more inclined, and Sylvia, if you could put up, yep, perfect. Are you more inclined to select a health plan for your employees or yourself that does not have a copay accumulator program after listening to this presentation? So the answers are yes, no, unsure. Okay, great. That's good to see. Okay, so we do want to thank our sponsors, AbbVie and Johnson & Johnson, and we now want to take some questions. So let's open up the question panel. So the first live question we have is considering heightened pushback against use of accumulator programs following the MBPP 2021 and the Medicaid proposed rule, should we expect to see an uptick in the use of maximizers? Rick, do you want to answer that?
Sure, and the answer is yes. We have seen a migration from sort of a traditional accumulator program to maximizer programs over the last 3 years. We see that in how the claim data comes to us. And we do think that some employers have come around to a certain extent to say that the pure accumulator program is a bit too harsh and the maximizer program is somewhat in the middle. So we do kind of expect to see a little bit more of that. Kaiser Family Foundation routinely publishes studies as well, and their surveys indicate that employers are, unfortunately, moving more and more to implementing some variation of an accumulator program, be it one of the two variants we looked at today.
Absolutely. So the next question is, it feels like an elephant in the room. What's the possibility of patients and employers using the energy generated by these nasty blunt force accumulator programs to gang up and use their leverage versus pharma manufacturers to lower their inarguably high prices in the US, so both patient cost shares and plan costs can be organically lower? So I think that's a complicated issue. There's definitely pressure for drug makers to lower their prices. I think the issue with copay accumulators is that essentially the patients are the ones caught in the middle of this fight between industry, the fight between drug makers and PBMs and health insurers. So that's why, as patient advocates, we advocate against copay accumulator programs, because the patients are the ones being punished while insurers and drug manufacturers are kind of negotiating how to lower the cost of healthcare, either through on the drug pricing side or the insurance side. Terry, Rick, I don't know if you have any other input you want to add here.
Not for me.
Oh, go ahead.
I'll just add very briefly, it is an incredibly complex issue in terms of drug pricing in the U.S. There's a variety of considerations. One thing to keep in mind is that the innovative drugs that are, produced each year are by and large coming from, the United States research and development. So there are a lot of different factors to consider.
Mm-hmm,
And I will, this is Jen Hepworth, and I will just echo what Stacy said, because this is the pushback I get back a lot when I go meet with my legislators is you need to be going after pharmacy prices. And what I have said is that is not my job. It is not my job to go and say, sorry, your medicine that's keeping my kid alive is too much. Can you please just fix that for me? And I don't feel like we should be bearing the brunt of the argument between the pharmacy and the insurance company.
Absolutely.
Well, And this is Terry Wilcox again. I mean, I'll chime in on that point and simply say that that part of it, there's way too many, you know, cooks in the kitchen, or whatever metaphor you want to use in that instance, of what is actually being paid and rebates and back and forth, and to ask advocates to go and navigate all that, like Jen, is ridiculous. I mean, many medicines have up to 85% rebates when you get into very common drugs like insulin and things like that, and it is a complicated thing to follow, and it does definitely need to be addressed and fixed, but it's not anything an advocate can do. It's to the point of things that we mentioned earlier in the webinar. It's like, you know, going into ERISA and making changes, you know, repealing, you know, all sorts of legislation. It's very legislative, a lot of it, and it has to be done. It can't even be done at the executive branch level. Some of it can be done regulatorily, like the MBPP and other things, but there's a lot that needs to be done, but it's going to take many moving parts, is what I'll add, and patients shouldn't suffer in the process of that.
Mm-hmm. Absolutely. So the next question is, who is driving implementation of these programs, and is there data on which states are implementing accumulators and maximizer programs most? So in terms of who's implementing, it's the pharmacy benefit managers and the health plans, and then also insurance brokers and agents are the ones that kind of market these programs to employers, don't always give the full picture on how the programs impact employees. Regarding data, Rick, do you know if there's any data on which states are implementing, or Terry or Jen, which states are implementing accumulators and maximizer programs most?
Just at a state level is not something we look at too terribly closely, because it's really the employer's ultimate decision to opt in, or, you know, to select a program like this. So, you know, we try to get visibility into the employer and the PBM relationship. So I can't really answer the state question.
Oh, go ahead. What should manufacturers do with copay programs if the value of these programs is counted against best price? So it's really hard to say. I mean, I think manufacturers will be put in a really difficult position. I don't know what the best solution for them is. They're probably going to want to push back against PBMs and insurers and try and find out if there is a way for which they can find out at least whether a plan is implementing a copay accumulator. So at least they know which plans are implementing. And then they're going to have to figure out whether they can still offer copay assistance or not. Unfortunately, there's no great solution here. Does anybody else have any input they'd like to add?
So from TravelCard's perspective, you know, we're working with the manufacturers on this today. There's probably kind of 3 potential routes with a lot of gray area in between. One would be that the assistance programs are discontinued for certain products if they're deemed not viable. The next may be that they drastically reduce the program benefits. And then the third may be that copay assistance programs are completely redesigned altogether so that they don't go through a pharmacy claim and the benefit is provided directly to the patient. It may result in a more cumbersome experience, but that may be another outcome.
Thank you. And then we had a couple of questions. Let me see if we have time for them. A couple of questions we received ahead of time. So why would employees feel maximizers are beneficial to employees? So I would assume that they assume, you know, that the cost is spread out over the course of the year. As Rick mentioned, there's no real copay surprise. However, there's still detriment to copay maximizers as well, because they're still insurers are still manipulating the system. This is not how copay assistance was intended to be used. And again, it doesn't spend down that deductible. So patients who were really relying on copay assistance to help with their deductible because perhaps they have large medical bills. You know, if they're a patient with cancer who goes to the doctor a lot, needs other treatments, chemotherapy, things like that, they're still going to be responsible for that full deductible. So even though it might seem like a better option, it still has its drawbacks. And then last question, I'll pose this to Jen and Terry. What do you want employers to know about copay accumulators? So kind of final thoughts or takeaway messages.
Jen, you want to start?
Sure. I just think that this is such a damaging problem for your employees. It's something that a lot of people don't realize, and like in our situation, we had no idea that this cost would be coming, and when our daughter was born, had no idea that she would be having cystic fibrosis. And so even your employees who may not have a condition right now, it can pop up at any time. When I was 21, I was diagnosed with an autoimmune disease, and now I also have expensive medications to contend with, and it is not anybody's fault, and it is definitely going to impact a lot of your employees. And to be able to have a plan that does not allow these copay accumulators is a huge deal for those of us with chronic conditions. And it's, in our case, it will be what my husband is looking for when he starts to look for his next job, because it will make such a difference for us financially.
And as far as what I would say is I would look back at the patient that I mentioned at the beginning, where he was imposed a copay accumulator by his employer without any sort of salary increase to help offset that. And so it's sort of like taking a pay cut in his mind. And there's many ways to design your plans and think about your employees, and there's many places to put your business. I mean, there's fee-for-service PBMs, there's other insurers. I mean, perhaps I understand the burden on employers as far as the cost of healthcare. It's rising in this country, and it has been for a while. So I do respect that, but I also just would say from a patient perspective to make sure you're exploring all your options before you burden your employees with this type of program.
Thank you. And I want to thank you to all our speakers today. Very valuable input and information that you shared. And also thanks again to our sponsors. And with that, we're going to end this presentation. Thanks, everyone.
On behalf of HR.com, I'd like to thank our sponsor, Aimed Alliance, and today's presenters for sharing this important information with us today. Thank you also to the audience for joining. We will be sending you an email with your credit information within 24 hours. You will also find the credits in your View My Credits page of your membership profile once the webcast has been archived. Your feedback is important to us, so please take a moment to fill out the exit survey that opened in a new browser page on your computer. I also added a link in the chat if you want to grab it from there. This concludes our webcast. Enjoy the rest of your day and stay well, everyone.